My name is Wei Chua. Welcome to today's session. We're excited to be a part of the panelist group discussing suicide risk assessment in pediatric hospitals, clinical pathways, and beyond. I'm an instructor of pediatrics at Northwestern University and serve as an attending physician at the Pediatric Emergency Department at Lurie Children's Hospital of Chicago. I want to thank the organizers and partners of the Illinois Suicide Prevention Alliance for giving me this opportunity to participate in this panel and to learn from our esteemed panelists. So today we have three panelists who will be presenting their work. We have Drs. Khalid Afzal, Dr. Kiati Bramnbhatt, and Dr. Brian Kurtz. Dr. Afzal is from the University of Chicago, where he is an associate professor of psychiatry and behavioral neuroscience, and serves as the Director of Pediatric Consultation and Liaison Service. Dr. Bramnbhatt comes from San Francisco, where she works at the University of San Francisco Benioff Children's Hospital, serves as an Associate Clinical Professor, and is the Director of the Child and Adolescent Consultation and Liaison Service. And then Dr. Kurtz is coming from Cincinnati, where he works at Cincinnati Children's Hospital. He serves as the Director of Child and Adolescent Psychiatry Residency Training Program and Child and Adolescent Psychiatry Consultation Liaison Service. The panelists today were all important parts of working groups at their institutions where they created clinical pathways for suicide screening. And I'm really excited to hear their presentations. I would like to let the audience know that throughout the presentations, we do encourage you to submit questions to the Q&A, and we will try to reserve a good portion of the time that we have to kind of have rich discussion. Of note, we have a total of 40 minutes today. So I would like to introduce Dr. Kurtz, who I believe will be presenting first.
Thank you so much for that warm introduction. I'm really happy to be here today, and I'm excited. We really will try very hard to leave a lot of time for questions because we're hoping this will be kind of a rich discussion. So I'm going to go ahead and start sharing my slides. I don't have any conflicts of interest to report. I have a small portion of my salary that's derived from funding for a study by the Patient-Centered Outcomes Research Institute. It's unrelated to this topic. So I first wanted to talk a little bit about why to screen all youth for suicide. And that may be obvious, especially to those who are kind of tuning into this a little bit, but I think there's some useful background to include. So one is that we know that youth suicide is a big problem and it's getting worse. In 2018, a study was published with data from 49 children's hospitals around the US that showed there was a steadily increasing rate of presentations related to suicidal ideation and suicide attempts. In 2019, the CDC released data showing a steady increase in the rates of death by suicide in adolescents aged 15 to 19. But at the same time, we also know that a lot of youth who die by suicide are actually being seen by someone in the healthcare field. There was a study that showed that actually was data spanning 10 years from lots of institutions showing that 40% of youth who died by suicide were seen by a medical provider within the past month before they died. And if you look at the past year before they died, it's 80%. So we feel like this is an opportunity to kind of be screening and identifying these individuals. At the same time, from a regulatory standpoint, the Joint Commission in 2016 released a Sentinel event related to suicide risk screening in medical settings. So to zoom out for a little bit and just talk about screening in general, what makes for a good screening. The best screener is going to be something that's going to catch almost all the true cases of something, whether you're screening for a mental health symptom like suicidal ideation or a medical condition like heart disease or COVID-19. You're going to want to have a screener that catches almost all of the cases of it. We want a screener to be quick because we're going to give it to a lot of people who will end up screening negative. We don't want to take up too much time and make it too onerous. And in the same vein, we want it to be relatively easy to administer and standardize so that we can really be rolling it out to a large population. We also want it to be validated. So we want to have it be checked against the best tools that we have to measure the presence of a condition or a symptom. This is not so much about the screener itself, but what you do with it. We also want it to be kind of clear what the next step in care is. If you respond, if there's a positive screen, what should happen next? And so today we'll be talking about the pathway that we developed that utilizes both a sort of like universal first screener called the Ask Suicide Symptoms questions, and then there's a secondary screener for those who screen positive, and we'll walk through that a little bit. So just again, kind of the structure is the universal screener that you might give to every child, say 10 or 11 and above, that's presenting, for a pediatric hospitalization or in the pediatric emergency department. That's going to take about 20 seconds, and we'll walk through the whole thing. The brief suicide safety assessment for those who screen positive to that is something that might take about 10 minutes. So definitely more time consuming, but still relatively brief, and potentially can be administered by a wide range of staff. And then a full mental health evaluation for those who screen positive to that is something that really needs to be done by a very qualified and trained mental health provider who is used to thinking about suicide assessment and disposition and things like that. And that's going to take a while longer. So to kind of walk through these Ask Suicide screening questions, this was developed at the NIMH by Lisa Horowitz and her colleagues. The 4 questions, which I'll read, are: in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? And then if yes, how and when? If a person responds yes to any of these 4 questions, they'll get a 5th acuity question, which is, are you having thoughts of killing yourself right now? How to interpret the responses. If someone answers no to all of the first 4 questions, that's a negative screen. They're done. If they don't respond to any of the first 4 questions, that's considered a positive screen. If they answer yes to any of the first 4 questions, that's also a positive screen, and they get asked the 5th acuity question. If the answer to the 5th acuity question is yes, that's considered an acute positive screen. Both a non-acute positive screen and an acute positive screen are obviously positive, but what you do in each of those instances is slightly different, as I'll show you in a moment. Individuals who screen positive receive the brief suicide safety assessment, and the NIMH toolkit walks through basically how to consider things like depressive symptoms, as well as frequency of suicidal thoughts and the presence of a suicidal plan, as well as past behavior related to suicide, stressors, and also potentially social supports that are available. There's input that's received from the caregiver as well as the patient, and it walks through making a safety plan, determining disposition, and providing resources. In the pathway that we published in 2019, there's a document that walks through, sort of how the pathway came to be, as well as a description of the pathway in text form and visuals, which I'll be showing you in a moment. There's also scripts for for instance, nurses who are doing an initial assessment on the pediatric floor of a hospital or in the emergency department might introduce the screener and things like that. So this is a zoomed out version. It's too small to read, but of the pathway that you would utilize on the inpatient medical unit, and I'll kind of walk through it a little bit from the point that an individual is given the ASQ. Again, if they refuse to answer, it's considered a positive screen. If they do answer and answer no to all four of the four questions, that's considered a negative screen and they're done. If they answer yes to one of the first four one of the questions, then they receive the fifth question. If the answer to that is yes, that's considered an acute positive screen. And if they don't answer yes to that, then that's considered a positive screen and they receive the secondary screener, the brief suicide safety assessment. And the outcome of that is one of three possibilities. It could be either low risk, high risk, or imminent risk. And so just to kind of walk through that further, individuals who are determined to be low risk by the BSSA, the Brief Suicide Severity Assessment, brief suicide screening assessment, would typically be appropriate for outpatient settings and receive referrals for mental health services in that area. And those who are either high risk or imminent risk really need that full evaluation by a mental health provider. So they'll get that full suicide safety assessment. In the case of an acute positive screen, at that point, it's appropriate to, even before anything else happens, really make sure that there's some safety precautions in place, either in the pediatric, on the pediatric ward or in the emergency department, because that person may be at risk for harming themselves in that environment. And then the pathway basically continues, after that full suicide safety assessment has occurred, that will essentially determine, is hospitalization needed? And then if the answer is yes, depending on whether the patient is being admitted for medical treatment or not, they may need to have handoff to either a psychiatric disposition where they're going, or to the medical units. They'll be taking care of them until they're potentially might be ready for inpatient psychiatric hospitalization. This is the same pathway, but in the analogous one for the emergency department. So again, too small to read, it's zoomed out, but basically the difference is just that this starts with the patient presenting to the emergency department and then quickly gets to the ASQ questions. As far as where you can find these, I think that these are slides that are going to be provided to you. So hopefully these links will take you to the pathway that we've published. But again, it contains, the visuals, the text description of the pathway, as well as how we developed it, and some scripts for how to utilize that. So that's all I wanted to share. I'm going to turn it over to Dr. Bramnbhatt for the next portion.
Thank you, Dr. Kurtz, for that amazing and concise description. So what I hope to talk about today is, how do you take all this information that's in a pathway that's more broad and general, and then apply it in real life clinical settings? I don't have any disclosures to share with you today. Before I go into the details of this slide, I want to highlight that this is a huge undertaking, especially when you're thinking about doing it across your health system, and education is going to be a key part of it. And we started off in our hospital by really listing all the stakeholders. So that would include nursing leadership, our social work leadership, physician leadership, and other sort of operational heads, to make sure that we were all on the same page and understood why we were trying to do this, and what are sort of our resources that are already available to us, what are we already doing that's aligned with this, and where do we need to make changes. And then the next step is going to be educating all the different providers, and finding ways to include the education in their usual sort of CME and other mechanisms, so that it becomes an ongoing process. And then once you've accomplished that, to then in parallel make sure that implementation becomes as easy as possible, so we reduce the chance of human error or people not remembering in the moment. And the way we did that is we basically took that pathway and had it set up in our EPIC, which is our electronic medical record, such that this screen pops up when the bedside nurse at triage in the ED or during admission on the floor, just brings the screen up and then asks the question of the ASQ that you heard about from Dr. Kurtz, and then clicks on the responses. And we have a backend built to this, so that based on the responses that the nurse clicks on, automatically there's a pop-up screen that comes up that tells you this is a non-acute positive screen. There's a similar thing that will pop up if it's a positive screen. And then all the next steps that need to occur are already outlined in this sort of pre-populated order set. And so that would include, calling social work, special food request, if there are sharps restrictions. You can change and uncheck and check things if you want, but there are things that happen automatically. So it really becomes easy for people to implement this. And so with that, it took us a year and a half, almost 2 years to get all of this up and running, get the build going. And I want to share some outcomes with you. This is from 2019, so the numbers for 2020 look different probably. But in that 1 year, from January to December of 2019, approximately 3,659 patients were screened. So that's about an 80% implementation rate, which we thought for the first time, for our hospital doing anything like this for mental health was pretty good. A majority of the patients, so 85% of those we screened were negative, and then about 8.5% were positive, either acute or non-acute. A majority of them were non-acute positive. About 1.3% were acute positive patients. So these were patients who said they were suicidal in the moment. And then when child psychiatry evaluated them, about 0.6% of the total screened, and then 25 out of 48, so kind of about 50% of the acute positives ended up needing inpatient psychiatric transfer. For the non-acute positive screens, that was about 7% of the total screened patients. And then after the BSSA, about 54 of those, or 1.4%, were thought to be high risk or imminent risk and needed psychiatry consultation. And of those, 19.5% of the total of the 3,659 ended up needing psychiatric hospitalization. So what this means is, in a year we had about 1% that needed inpatient psychiatric transfer, and about 7 to 8% that had any sort of positive screen. To us, that was reassuring because we felt like that percentage of volume we could handle, and it actually mirrors a lot of the adult numbers that are published for similar screening implementation. So the next thing we wanted to do is, look at, okay, so of the people that are ended up needing either inpatient hospitalization or screening, acute or non-acute positive, if the majority of them are kids who have a prior psychiatric history or are coming in for a psychiatric chief complaint, then maybe we don't need to screen everybody. But when we actually looked at our numbers, we found that of all the patients who screened positive, nearly 60% did not present with a psychiatric chief complaint, and about half of them had no psychiatric history in the past. The numbers kind of get smaller. In the acute positive screen, about 27% had no prior history, and 10% did not come in with a prior chief complaint. And then the non-acute positive screens were somewhere in the middle, but still 70% of the non-acute positive did not come in with a psychiatric chief complaint. And this was really important for us to sort of recommit ourselves to saying we need to screen everybody, because we would miss a big chunk of patients if we only focused on patients with mental health history or presentations. The next step that we're doing now is looking at it in a much more granular fashion and looking at each of our units to see where are we doing a good job, where is screening lagging, and how can we improve that. And some of the numbers here seem intuitive. Our medical surgical sort of floor does the best job of being able to screen patients, and our cardiac transitional care unit and some of our ICU, that's been lagging. But this is early, sort of first 6 months of implementation, and things have improved since then. And so now we're in a phase of sort of more targeted education and more targeted interventions to improve that. So I think this has been really helpful for us to do this in a more global fashion and take care of all our patients. The next question has been, can you do something beyond screening and connecting them to outpatient resources while you're still with us? And I'm going to pass it on to Dr. Afzal, who will talk a little bit about what we can do in the hospital. Thank you.
Okay. Screen. Okay. Thank you very much, Dr. Bramnbhatt, for a wonderful presentation, and Dr. Kurtz as well. And thank you, everybody, for joining us for this summit. So I don't have any conflicts. So the year was 2013 when Dr. Boudreau at UMass came up with the idea of ED SAFE. And as Dr. Bramnbhatt mentioned, that once we have kind of assessed what to do with those patients, So the idea basically with Dr. Boudreau came up with that after the screening in the ED, and he's talking about the adult patients, dividing the patients into two groups. One group is going to receive treatment as usual, and the other group, after universal screening, will receive a brief ED intervention focusing on what to do when you become suicidal, like kind of a safety plan. And basically with post-ED counseling. Now, this is something which was crucial because post-ED counseling was for about a year by monthly calls. So in 2017, the study was published, and I think it was also reviewed earlier in the summit, I think yesterday a little bit. There was a significant difference between the control group, which received the treatment as usual, versus the group that received a brief safety intervention in the ED and thereafter, post-ED phone calls. And there have been now several studies showed that even a brief contact after the ED visit, where patient is there for suicidal ideation, it decreases overall risk of suicide. So with this idea at the University of Chicago, we came up with some modification to the original ED study, and we are calling it as PED SAFE study. So the difference from ED SAFE, our study a little bit different from ED SAFE study. One of the things is that in the original study with adults, safety plan was self-administered, basically. What we are doing is that our clinician, our study investigator, or the ED clinician is going to be working with the patient to develop the safety plan. And I'll be talking about which patients, how to select those patients in just a minute. Instead of one monthly call for a year, we are going to be doing in our feasibility study one weekly follow-up call. In the original study, they wanted to talk with the patient alone because it was an adult. We are modifying it because at times, parents are unavailable, or maybe family system could be a cause of conflict. In those situations, we would like to speak with the patient without the parent, or maybe both, or sometimes only the parent when youth is not motivated to participate. That can happen as well. And lastly, in ED SAFE study, when the patients did not respond to the follow-up calls, they would send kind of a personalized letter sharing the concern of the clinician. What we are thinking is to send personalized letters to all patients after the intervention. And there are two purposes. One, it is kind of, we are going to see if it becomes kind of a motivation for the patient to participate in the follow-up calls. And secondary reason would be any contact with the patient after ED can decrease suicidality. So this is an open trial. The big difference is that we won't have any controls in our study. In our study, we'll be focusing on two groups, as Dr. Kurtz explained, in the low risk, basically right here, and the high risk. High risk, after they have been evaluated, with full suicide safety assessment and deemed not meeting medical necessity for inpatient hospitalization. So So the imminent risk group or the individuals in high risk group, they are deemed like kind of imminent risk. We are not going to be working with those. So we are going to be working with patients who are low risk or high risk, not meeting medical necessity for inpatient hospitalization in the ED while they are waiting there, basically. We are going to get written consent and assent. We'll start by explaining what exactly we are trying to do. We are going to develop a safety plan with them. We are going to be meeting with the patient and the parent separately. We are going to see what kind of outpatient treatment providers or availability there is. And last but not the least, we are going to schedule the first call in a week after their ED visit. While they're waiting, we are also going to do some questionnaires with them, including this brief hopelessness scale, PHQ, major depression, major depressive disorder, bipolar, generalized anxiety, and so on and so forth, just so that we have some objective data as well. It will take around 15 minutes. And then so this measure is focusing on youth, like the patients, which in our study would be 13-year or older, 13 through 17, and also some baseline measures with the parents. This will take around 5 minutes. During our weekly telephone calls, we are going to definitely provide support to the family, just evaluate for the risk. We are going to do some follow-up measures, including, again, suicidality. And then we are going to discuss what was their engagement in treatment, did they adhere to the follow-up plan, and then review the personalized action plan that was developed earlier, and whether it needed any modification. The total expected time in the ED with the patient is around 20 minutes, with the parent is around 20 minutes, and follow-up call anywhere from 6 to 20 minutes. So it's about an hour. Intervention might be a little bit more or a little bit less, depending on the circumstances. And I feel that with proper education, risk assessment, interventions, and policy, we can reduce the risk in suicide. And absolutely, we all believe in together we can. Thank you very much. And this is a picture of our group when we developed the pathway. And the arrows we are hidden, Dr. Kurtz, myself, Dr. Bramnbhatt, and Dr. Horowitz, who presented yesterday, was a wonderful mentor for all of us and colleagues. So thank you very much. And now we are open for questions.
Hey, thank you guys. That was a great presentation. I really appreciate the clarity in how you presented the work. So I do want to take this time now to open it up to discussion. So let me see the chat if there's any questions. There was one question that did come through the chat in regards to utilizing schools as an opportunity for screening. So was curious for you guys to kind of elaborate on that.
I can just take a stab. I know that there are efforts underway to validate some of these screens in school settings to make sure that, given the different prevalence rates and such, that it's valid in that setting. And I do think it's an important setting to really identify patients and youth that are at risk. The key to this is making sure that we have solid workflows in place as to what occurs once the screen is administered and somebody's identified at risk. And so that would have to be sort of taken up at individual school sort of districts and what resources are available and how they can, make sure that the kids, if they're identified, receive appropriate levels of care. But I would love to hear what some of my other co-panelists think.
Yeah, I just want to, echo everything Dr. Bramnbhatt just said. I think, you'd have to have a workflow in place for positive screens, and with everybody knowing that many positive screens don't require inpatient psychiatric hospitalization. So you have to be able to say, okay, this was a patient that something came up, we wanted to make sure we didn't miss anything, and so we were able to sort of get it, followed up on, but we do understand that they didn't require an inpatient hospitalization, and they're coming back to school appropriately, those kinds of things.
I also agree with Dr. Kurtz and Dr. Bramnbhatt. I would just like to add that on the surface, I think the question is very, very valuable and very important. But when we really divide schools and school districts according to the resources that Dr. Bramnbhatt said, it really changes the question, because I know many schools where there are not even nurses there. So I think it could be started as a pilot project in certain schools with more resources in certain areas, and then probably expanded. One of the first steps probably would be to educate in identifying early warning signs for teachers and also for social workers there and also nurses. So I think that would be a positive step towards achieving probably at some point in screening in school.
Thank you, guys. I know a lot of the attendees who are listening to the panel discussion today may be working at institutions that are starting to create their own pathways and to implement the ASQ in their own workflows. Question that I think would be helpful for all of us is, could you guys talk a bit in terms of the actual implementation at your institutions, and how did you get buy-in at the respective areas? We may all work in different areas. Like I personally work in the emergency department, but critical care, medical surgical floor. So what barriers may have existed, and sort of what strategies you guys employ to kind of get buy-in in those respective areas?
I think if Dr. Brown can start, and then I can add maybe a little bit.
I think in addition to what I already shared, clearly it being a joint commission, Sentinel Alert goes a long way, because hospitals sort of have to do something. But that's only true in hospital settings. If there are implementations in outpatient settings and integrated care clinics and such, so buy-in is important. Oftentimes for us, our discussion started by just looking at, how much time, energy, effort, baseline sort of work is going into addressing kids who are showing up in acute distress with mental health emergencies. And all of my colleagues in pediatrics would agree that it really is a significant amount of what they're doing, but they don't feel prepared to do that. And then this is one way to consolidate it, and having the numbers to show that this is not going to be, what some of my colleagues call like a tsunami of patients who are positive, that, every patient that we screen is going to be positive. That helps to sort of understand it's going to be a small percentage of the overall population, but at the same time, it's a very important percentage to screen, because we would miss a lot of them if we only focused on those who we already know have mental health issues. And so that's been really helpful. We've had a number of cases where they presented for completely unrelated things, so somebody came in for an orthopedic surgery. There was no concern that anybody had about mental health, and that patient screened acute positive and needed inpatient hospitalization. And so some of these case stories and really talking about the individual patients can be really powerful with our clinician colleagues, and getting buy-in and helping them understand sort of what we are trying to accomplish. That's some of it. And then, on the other end, when they say, well, in the outpatient clinic, I don't have a ton of child psychiatrists I can refer to if I'm screening, and I don't have these resources, then what are we achieving? And I often talk about the one thing we know that really works is means restriction. And then we also have data to show that a lot of kids who experience suicidal thoughts and suicidality don't often share it with their family members or parents. And so if you're screening, and if all we are accomplishing is letting the family know, planning with them for safety and means restriction, that in and of itself is an intervention. And then, then sort of in an integrated care model, expanding the ability of the pediatrician to provide some sort of basic intervention can expand on their ability to do that. And then you're always there for the sort of very high need in a stepped care fashion patients. So that's what's helped me in my system to get this going. But every system is different, so I'm curious,
Yeah.
Dr. Afzal and Kurtz.
Yeah. So what I felt, in fact, I sought a lot of guidance from Dr. Bramnbhatt from her experience. I think buy-in is extremely important, and clarifying the questions, like Dr. Bramnbhatt said, that I think how I did in my institution at University of Chicago was first to present a grand round, a pediatric grand round, explaining pathway and the need and everything. I think that was the first step. Talking with our ER colleagues, pediatric ER at Comer Children's Hospital, very, very, very important. I think most important is the administration. We have to have buy-in at the highest level because it's going to require resources to modify EPIC or other EMR or other systems, whatever hospital or institution is using, and maybe some additional staff possibly needing at some point. So all of these things require some kind of, numbers. So we really feel, Dr. Bramnbhatt, Dr. Kurtz, that buy-in starts at grassroots level, working with our pediatric colleagues, ER colleagues, and then higher up at the administration level, both. Clarifying what exactly is happening, why there is a need, and if it is not going to happen, what's going to happen. So all kinds of answering the questions. Last but not the least, our pathway is also listed on Joint Commission website. So just people, FYI.
Yeah, I think that's all very well said. At my institution, actually, it's definitely been an evolution because I think, like a lot of places, like I think our hospital had a way of doing things, and they said, we have a way that we're screening for things, and it's folded into our initial nursing assessment. But if you look at it, it wasn't evidence-based, it wasn't validated, and that's a major minus. So I kind of brought that issue up and have kind of stayed with it. And what has made the difference is that the institution embraced sort of a zero suicide initiative. This, I don't know if people are familiar with this, comes out of the Henry Ford in Detroit, but a sort of a set of interventions to try to reduce youth suicide. So I kind of brought up again, we have a validated way of doing this, and it's really worth taking a look at. So I think everything that Dr. Afzal and Dr. Bramnbhatt said is absolutely true. And sometimes there's value to, you kind of bring it up and you kind of stay with it, and you're ready to sort of seize the opportunity when it presents itself.
All right, thank you for those responses, guys. That was very enlightening. I want to thank the attendees who have sent questions. We have a lot of really great questions. We're running a little bit low on time. We only have about 3 minutes left. So just in light of the current political climate and a lot of the attention that has been focused over the last year, I'm just kind of curious, has there been any issues with like implicit bias or implementation of these screenings as it comes to sort of minority populations? And what strategies have you guys employed to kind of address those potential conflicts?
I can, talk a little bit about at least the data that we look, because that was actually one of the questions. I haven't presented on it today, but it is one of the things we were looking at when we pulled our data from 2019 and looking at demographics, and to see if there were significant differences in either who was screening positive or what resources were being allocated. We didn't find any statistically significant difference in race, ethnicity, insurance status, primary language of the family, based in terms of who was being screened or not screened and what kind of screening outcomes were happening. There was a slight trend towards patients who are Black race or public insurance needing more or ending up in that bucket with increased rates of transfer to inpatient hospitalizations. Our total N is pretty small to like really parse that out further, but our hope is that we are going to, look at, our hope is that we were going to initially look at that number in 2020, and hope that it would be powered. But I think 2020 is going to be somewhat different now because of the pandemic and how that impacts things. But we are continuing to collect some data on that to really try and answer that question. Is there a role for sort of institutionalized racism or implicit bias, and why that outcome was happening? And first of all, like, is that trend actually statistically significant when we look at more, when it's powered correctly? Translating these instruments, sorry, one more thing I will say is translating these instruments in other languages is also very important. Like the ASQ is available in many, many languages, which is, I think, great. And, I know Dr. Afzal has worked on like its Urdu translation. So the more we can make it broadly available in various languages, I think is also another important factor.
Yeah, thanks, Dr. Afzal, Dr. Bramnbhatt, and Dr. Kurtz. Really appreciate your time. It is currently 4:20, so I do want to be mindful of the next speaker. So I would like to pass the baton over to Dr. Bergman, who will be presenting Dr. Hoffman's presentation. Thank you, everybody.